Recording?
Probably.
Okay, it should be recording now. Hopefully it works. So, welcome to our, I guess, week-long or weekend-long review of the whole GIT system. Today, we're going to go through anatomy and embryology, kind of like together in a mixed batch. It's a fairly long one, so I'm hoping you guys brought snacks or something to keep you kind of like powered throughout. Alina's grabbing something. I don't know what that is.
I got my snacks ready.
But yeah, so it's going to be a pretty long haul. You guys got the slides beforehand, and you guys probably have taught stuff. So hopefully you guys will know some of the stuff going in. But especially for things such as embryology, if that's confusing you, feel free to stop me through it. I heard that was difficult to begin with. I don't know if it's still difficult now. But yeah, if you have questions, like we said before, message the group chat. Hopefully one of us will see it, and hopefully we can give you guys a good answer. But if you guys don't have a question to begin with, we might just get started. If you have any questions, spam the chat now whilst I start sharing my screen. Forgive my like messy as. All right, let me go to not see it. All right, so gastrointestinal system, a review. So GI, Abdo, and Nat. So this is the first part of it. We're going to talk about the abdominal wall, and this is surprisingly important, I guess. There are two different, I guess, ways to draw it or ways to visualize it, and they are two anatomical different sites. This hopefully should know, and they are both different above and below the arcuate line. The arcuate line is just an imaginary transverse line where the inferior epigastric vessels perforate the rectus abdominis muscle. I'll give you a little picture of that in another following slide. But this is kind of the picture you get up, above it, and this is the picture you get below it. Feel free to zoom in or get this picture basically off Google when you see the slides. So above the arcuate line, the order will go from skin to superficial fatty layer of Camper's fascia, and then the deep membranous of Scarpa's fascia. In a way to remember this, you can think of Camper's as like camping. You're going outdoors to camp, unless you're like glamping or something, at which point you're going to be outside. So therefore the superficial layer of Camper's fascia is going to be on the outside. Then you move to the aponeurosis of the external oblique and the internal oblique. The aponeurosis is kind of this fibrous stuff that's from these muscle layers. And then the rectus sheet is then below it. The rectus sheet, this is called the rectus sheet. So these aponeuroses are the anterior rectus sheet, so this area here. Then you have the rectus abdominis muscles, which is effectively just your abs. And then the aponeurosis of the internal oblique and the transverse abdominis on the other side. So basically what you have is you have the external oblique, the aponeurosis of the external oblique on top, and half of the internal oblique aponeurosis on top, and the following half on the bottom, as well as the transverse abdominis aponeurosis down inside, which is the posterior rectus sheath. You then have the transversalis fascia, and then below that is the peritoneum, which we'll get to later. Then below it is a very similar idea, except all of these aponeuroses are above the rectus abdominis, making the solitary anterior rectus sheath. Whereas before you had this kind of splitting of the internal oblique aponeuroses below the arcuate line. You don't have that. This is kind of what I was talking about before, when this is the point where the inferior epigastrics cross into the rectus abdominis muscle, is where this difference starts to happen. I guess some other fun facts, just because this is something they might tell you and you might be like, what the heck are they talking about? The linear elbow is that line in the middle, so I guess it'd be like here. That separates, I guess, the six pack, I guess. And the semilunaris is on the other each side. So these areas here would be called linea semilunaris, and they're just lines given fancy names for no reason. Okay, so the muscle layers, the abdominal wall. So some of these details that I've given you aren't the most important. So sometimes I've given you innervation and arterial supply, and they're not the the most critical things for you to learn. The reason I've given them to you is because sometimes I found last year, I was like, what's the innovation of this random thing? And this would help. So this is like for fun facts, some of it. But what's important here is you have to know what they look like, or typically look like. And this is something you probably would have done in specimens if you had specimens, but the external oblique fibers will run inferior medially. So if you can still see my camera, hopefully it will go downwards, as in like hands in pockets sort of style. The internal oblique fibers will then run inferior laterally, which is the perpendicular way. So like that instead of like that. Hopefully that makes sense. I can't see any responses, so hopefully that works. The transverse abdominis muscle is just then behind it, and the rectus abdominal muscle is the abdominal muscles in between. They are supplied by the inferior epigastric arteries, from the external iliac artery, which is the ones in your legs. Yeah, from that, not too much important there. In terms of the structure of the posterior abdominal wall, there's not a heap to talk about here, but they like quizzing you, or they would have liked quizzing you on this in imaging. But there are 4 real groups of muscle that you really need to pay attention to. And this is the lat dorsi, deep muscles of the back, or the rectus spinae, and the quadratus lumborum, or the psoas. I guess what you can think about and how to visualize it is the rectus spinae is this kind of like circular muscle block next to the vertebrae, behind the vertebrae, so posterior to the vertebrae. The quadratus lumborum is this sort of, I don't know, square, like rectangular like muscle that just exists. It actually is quite like 4-sided, which is helpful. And then the psoas is this muscle that's, I guess, more anteriorly located, to the vertebrae. And then latimus dorsi is this muscle at the back. They are separated by fascial layers, which is why you can actually see them, separate them out. But yeah. The neurovasculature of the abdominal wall. So there aren't many vessels in the nerves in the abdominal wall, and frankly, even less that are that important. Looking at the thoracoabdominal and subcostal nerves, there's not a heap to pay attention to. They are dermatomal, so they'll come in like their dermatomal lines, and they wrap around from the posterior to the anterior, traveling deep to the transversus abdominis muscles. They emerge lateral to the midline, i.e. this is the midline. They emerge around about here, and then they will go out and then go left and right to give cutaneous supply, basically. They'll also come out kind of halfway as a lateral branch, but that's less useful and less important. This is important for the incisions I'll talk about in a sec or later. Basically, you can cut straight through here and not risk anything. It's kind of idea though. Similar course exists with subcostals. Just as a fun fact, I guess, almost, the superior epigastric artery will come from the internal thoracic arteries. So the ones, hopefully you remember from when Alina gave her presentation on the thorax, when I gave it last year about cardiac, the ones behind your sternum. Okay, otherwise those are the internal mammary arteries. And then the inferior epigastric will come from the external iliac, and they will supply the abs, like I said earlier. Okay, so testicular descent. This is part 1, or one of the first areas of, I guess, an embryological perspective. So testicles begin the development of the posterior abdominal wall. So they will start retroperitoneal, and I'll talk a little bit more about that later, and will descend through the 7th to 12th weeks of development. Do you necessarily need to know that 7th to 12th week? I don't think so, but it's also something that's very easy to assess. So it's not that hard to remember, I guess. The descent begins as a result of the growing abdomen, as in the gubernaculum, which I talk about here, doesn't pull it at the beginning. It moves down towards the testes because of your growing abdomen, and it'll move through the inguinal canal, which I'll talk about in a sec. As it does this, it pulls through all the layers of the abdomen, part 1. And as it goes nearer to the end, the gubernaculum will then shrink, otherwise known as a scrotal ligament, and pull the testicles into position. The peritoneum that the testicles push through goes at the anterolateral side only, and this is kind of important. You don't really necessarily know it's anterolateral, just know it's something like the front, so the anterior. And this becomes the processus, first becomes the processus vaginalis before then become the tunica vaginalis. Initially, this means it's an open tube in males, and this will eventually close. But this is an important detail because if this fails to form or forms poorly, i.e. the whole thing, this whole thing is covered in this tunica vaginalis, you get something called bell clapper's deformity and allows you to get testicular torsion, or puts you at risk of getting testicular torsion, whereby your testes effectively just get ischemic because the testes will twist, blocking off the venous drainage, I think, from the testicles. Effectively, they become ischemic, and that's a fair big emergency. The testicle layers will mimic the abdominal wall layers, as I said. The only one they miss is the transversus abdominis the transversus abdominis layer, as it was way too, I guess, superficial. So you'll notice here that this transversus abdominis layer in this diagram is absent, and is absent in this kind of diagram where it showcases it pushing through. So if you imagine what's going on here, this is the testicle, I guess. It pushes through all these different layers and goes through. This diagram is quite good. I would remember this diagram and learn this diagram, I guess. These are then the kind of mimicking layers. So the dartus fascia is the scarpus fascia, external spermatic fascia is from the external oblique, cremaster muscles from the internal oblique, tunica spermatic fascia is from the transverse abdominis, and then tunica vaginalis from the peritoneum. This is kind of useful, and I think it will come back again in next semester when you look at the pelvis and things like that. They will just talk about it really quickly though, so it's kind of useful to have a good idea of it to begin with. And it's also something they can assess where they kind of go, what is the representative layer for the external oblique in the testes, for instance, and they might say that. So that's kind of what the point is there. Okay, so the inguinal canal. So the inguinal canal is very complicated. But it's angled obliquely to prevent the free flow of the abdominal contents through the canal, but still allow the testes to pass through. Because if you have free flow, you get things called hernias. In case it's supposed to get inguinal hernias, and that's not great. And that's kind of what it is. I've given you a lot of details in terms of what these layers are. I'm not really going to read these out to you because it's a bit redundant and you can kind of read it yourself, and because I can't really tell you anything more interesting than that. But I'll give you a couple of ways to learn it in this next slide. So this is kind of a continuation description. These formal descriptions read, but they're kind of complicated. So I'll give you guys a simpler version. It contains in males a sphenic cord and in females a round ligament. In both genders, it will also include the ilio-inguinal nerve and the genital branch of the genital femoral nerve. And like I said, if the processus vaginalis fails to regress, it will cause something called an indirect inguinal hernia. And we'll talk a little bit more about indirect and direct inguinal hernias a little bit more in a sec, but I think that's a pathology slide as well on Sunday. But I'll talk about this in a sec. So this is the inguinal canal diagram. It's messy, it's complicated, and that's kind of just is what that is. There are a couple of ways to learn it better. So how do you learn it? I don't think you really do have to learn it to like so much extent, but this is one of the ways to learn it, and there's two ways to kind of think about it. So the MALT mnemonic. So MALT stands for muscles, aponeurosis, ligaments, and tendons. I don't know why my last T is like not formatted the same as the rest, but regardless. The muscles make up the roof, and this will be the internal oblique, transversus, and abdominis. Internal oblique and the transversus abdominis muscles. The aponeurosis form the anterior wall, of which is both the internal and external oblique muscles, the aponeurosis. The ligaments make up the floor, so the inguinal and the lacunar ligament. And then the tendons, the transversalis fascia will make up the posterior wall. That's kind of like all you need to know about the walls and what's going on there. This is a different way to think about it, a different way to look at it. This is a model, and it works a lot better when you have the model in front of you. But I've given you hopefully enough pictures that you could maybe make it yourself. But the idea is that this is kind of what it looks like. So the structures effectively curve up in front of each other as they sort of move across. And that's kind of why you don't have like this, you have a tube that forms from these called flat layers, if that's what makes sense. This is the view from below, where theoretically there'd be an inguinal ligament and a lacunar ligament sort of blocking up the supply. I would spend time looking at this diagram and looking at these models to kind of get an idea. There's not a heap I can do just to point it out, but these says external oblique, internal oblique, and transverse abdominis. And that's kind of what that is going for there. Does that make sense? Hopefully I can get it somehow shown. I have no way to see the chat, is what I've realized. Anyway.
I'll let you know.
Yeah, we'll let you
if
know.
anything comes through.
Okay, cool. Hopefully if I don't get anything, that will make sense.
Or I mean, you can always like unmute and interrupt as well if you're feeling brave.
Yeah, if you want to. All right, how am I tracking the time? All right. Okay, so the incisions of the abdomen. So there are a variety of different ways to get through into the abdomen. They aren't that important to learn, but they got taught, so here we go. So the midline is exactly how it sounds. It's a midline incision. It's good because it's fast, but it's bad because it doesn't heal as fast. And they're for the same reasons. So it's good because you can get through quite quickly with no risk of major blood vessels or nerves damage because of that way they're kind of drawn out, as I described earlier. So the distribution and how they move and the way they sort of progress. But the same is sort of a reason why they don't heal. So because there's not much blood supply, or there's not major blood supply, it heals slower. And there's also a risk of an incisional hernia, which is where the abdominal sort of organs and the intestines basically just go through this wall, which doesn't sound great. A paramedian incision is when you just go left of the midline. And it can be done either as a lower or an upper cut, as in it doesn't have to be this full straight down line. It can be lower or upper. Transverse is a horizontal cut across the abdomen. It's good because it causes less pain when you sit up because it doesn't fold. But it's bad if you make a mistake. So if you cut this line open and you realize you need to go down much lower, then you can't really get there. If in kids though, it's not as big of a problem because they're just smaller. Continuing with the incision, so subcostal is this one here, where they just go under the ribs, the right lower ribs, and is used for gallbladder removal, also known as Koch's incision, apparently. Steeple is a bilateral subcostal, so it's the same thing but done on both sides, used for liver transplants. Apparently it can cause a flappy anterior abdominal wall because you're cutting off or denervating the tissue by doing this. The Perfanon steel is a little V incision in the suprapubic region used for gynecological surgery rather than bowel surgery. And then laparoscopic surgery means they use small kind of incisions for ports where they put cameras and their tubes and their sticks for like their cauterizing things. There. Okay. So now we're going to look at the other side of the interior abdominal wall, where, for instance, I want you to imagine you're basically, I don't know, the intestine looking out. So imagine you were the intestine and you were looking at, I don't know, the front, if that makes sense. What you'd see is the back side of the interior abdominal wall. And one of the most important things on there is Hasselbalch's triangle. This is this purple region here in this diagram, and if it's important because if a hernia arises going through here, they're termed direct inguinal hernias. Importantly, they are medial to the inferior epigastric artery. It's bounded by the inguinal ligament, the inferior epigastric artery, and the lateral border of the rectus abdominis muscle. But the most important factor is that it's medial to the inferior epigastric, and then it's the site for direct inguinal hernias. It's termed direct because it goes directly through the abdominal wall. Well, at least that's how I see it. I don't know if that's the actual reason, but it goes direct through the abdominal wall, and that's why it's an direct inguinal hernia. An indirect inguinal hernia will go through the deep inguinal ring, as in it will go indirectly through it rather than directly through the wall. It goes through the hole, basically. This is important. They assess this like every time, I think, or at least they really care about it. The umbilical folds, they also, for some reason, care about a lot. I think it's probably because it's got embryology in it. But these are the ridges of the peritoneum, which form folds, and they are from obliterated vessels and they are also end up calling ligaments. So they can be either called folds or ligaments, and there's like 3. So the median, the medial, which will go there, and the lateral, which will go there. The median and medial folds are obliterated fetal structures. So the median is the obliterated fetal urachus, so how they peed basically, and the medial fold is from the obliterated fetal umbilical arteries, which originally came from the internal iliac artery. This is like a question from our exam, so I don't know why they wanted us to know that, but it was a thing. I think it's more the idea you could work it out, but it was a thing. The lateral fold holds the still functional inferior epigastric arteries, which came from the iliac artery. Okay, so the lateral fold is the one that still has something in it that's useful. The median and medial fold have obliterated structures that Monash care about for some reason. But apart from that, that's about it. Okay, so this is also something that's quite important. So this is dependent locations of the abdomen. So these are basically spaces where fluid will build up when you're lying or standing, or mostly lying down flat, supine. And this can be blood or it can be fluid from infection. It's just a fluid in general. So in both sexes, the hepatorenal recess, or the pouch of Morrison, is the area between the right lobe of the liver and the right kidney and the right colic flexure. Effectively, just this little area here. Otherwise, drawn more excessively as this sort of area here. In males, there's also a rectovesical recess between the bladder and the rectum, but the more important one, because they just talk about it more, is for females, the rectouterine recess, the pouch of Douglas, which is the area between the posterior wall of the uterus and the rectum. So these are important locations for you to remember because they are areas where fluid will build up when people lie there for a long period of time. Okay, so the Transfollow Plan. So this is also something that's very important. I want a list of things that are important right now, apparently. So this is a radiographic plane, meaning it's a line in your body where radiographers can see a lot of things, or radiologists can see a lot of things. It's theoretically the level of the pylorus, but that changes with how much you're breathing in, if you're pregnant, your age, and all that kind of stuff. Because everything in the abdomen is kind of just like wherever it wants to be, realistically speaking. But it's theoretically the level of the pylorus of the stomach. So importantly, the Transfollow Plan is at the L1 vertebrae or the 9th intercostal cartilage. Both of those are important landmarks for you to remember because I think faculty or the anatomy department have realized that we learn L1 vertebrae like to death, but they realize we don't learn the 9th intercostal cartilage to death. So what they do is they kind of ask, what structure is at the 9th intercostal cartilage? Or they'll go, the fundus of the gallbladder is at which intercostal cartilage, which makes things a little bit more tricky if you don't know the 9th intercostal cartilage is the same thing as the left L1 vertebrae. So those 2 points are important for you to remember and learn. The ones that I've bolded are the important ones to know. The rest sort of just exist and you can learn if you want to. Well, actually, I'd learn them, but the ones in bold are the ones that will more than likely be assessed. The origin of the SMA is very important. The fundus of the gallbladder and the hilum of the kidneys and the hilum of the spleen is very important. These are the vertebral levels of the abdominal structures. So basically, this is where generally your structures will be in a vertebral layer. This is important as well. I would learn this basically like word for word. But in terms of arteries, there's a celiac trunk, the SMA and the IMA at T12, L1, L3. You can think in terms of visually, in terms of where they are. Celiac trunk and the SMA are very, very close together. So you can think, well, therefore they're going to be right next to each other. The IMA is just then L3. The aorta then bifurcates at L4, and the IVC will unify at L5. So technically, it's just a vessels, not arteries, but don't worry about that. The viscera, I've bolded the ones that are again sort of useful and sort of important, but there are a lot. But the left kidney goes from T12 to L3, and the right kidney goes from L1 to L4. The left kidney is higher because the right kidney gets pushed down a little bit by the liver. The suprarenal glands are both at T12. So even though the right kidney is lower, the suprarenal gland or the adrenal gland is pushed by the IVC to be the base of the same position anyway. The fundus, the gallbladder is at L1. This was something they asked us in our exam last year. There are other ones, as you can see in this sort of diagram here, but these are sort of the important ones that I would suggest you learn first before kind of going to anything else.
And also the renal arteries, they come off at L2. So it's easy to remember because there's one thing that comes off at like every vertebral level from T12 to L5, basically. So the renal arteries come off in between SMA and IMA.
Yeah, as you can kind of see from here, L2. But cool. All right, so this is where we start off. We're talking about embryology. And there's a lot of embryological stuff. Realistically speaking, the best way to learn a lot of this stuff is to just watch the video over and over and over and over and over again. I have a link to the video in this. I mean, I'll talk about it, but there's a link to the video in this that I would suggest you guys really watch because it's quite good to see. But if didactically getting told it helps, then we will try that. So all abdominal viscera, excluding the spleen and the kidneys, will come off the gut tube. You guys got told spleen comes from magic, and we will live with that logic until we get told it's wrong. And frankly, that's all I care about. The gut tube is derived from the endoderm, and the gut tube is surrounded by mesoderm, which will eventually form the adult mesentery and the peritoneal lining. So this is endoderm, this is all mesoderm. This is kind of important. They will generally ask this question. So make sure you know this, at least that fact. The mesoderm that directly touches the gut tube will become the visceral peritoneum in adult life. This works basically the same way as a pleura did in the lungs. It doesn't actually happen the exact same way, but visually and logistically speaking for you guys, it just is the same thing. Behind it then is 2 layers of visceral peritoneum which touches each other. And this is termed mesentery. Technically, mesentery has its own definition by itself, but the way people talk about mesentery, it's just this sort of structure here. It's 2 layers of visceral peritoneum that kind of touches itself. So it kind of goes this circular thing, and then it goes together, and then it comes separate again. But this together bit is just called a mesentery. Within that, the vessels and nerves will run through it, because if I don't know if you can see on my camera at all, but if this blue pen is sort of a vein, I guess, actually no, an artery, the 2 mesenterial layers on the other side will go around it. It doesn't go through the mesentery at all. It just goes through the gap, basically. The remaining mesoderm that kind of develops around the abdomen will become the abdomen, will become the parietal peritoneum, which is this red stuff over here. Okay, so this is important terminology. So intraperitoneal means the structure has peritoneum on all of its sides. Theoretically speaking, there's a bit at the back where it doesn't, but for our purposes, it does. Okay, so it just has a structure which is completely covered on all sides by peritoneum, so an intraperitoneal. Retroperitoneal means the structure started developing behind the peritoneum. It only touches one side of the peritoneum at the end as well. Secondarily, retroperitoneal means the structure began intraperitoneal, as in it came off the gut tube, and then during develop, it lost that posterior sort of layer of mesentery, and therefore became retroperitoneal, or made it look like it's retroperitoneal. This means that everything that came off the gut tube has to be, at the very least, secondarily retroperitoneal. This is developed to some degree in the foregut. There's mesentery of both sides, dorsal and ventral sides, as a result of kind of the folding that occurs. That doesn't really matter. But in the mid and hindgut, there's only mesentery in the back. So that's kind of why when you're looking at sort of the small intestine, there's also kind of this mesentery at the back. Whereas when you look at perhaps the stomach, there's this lesser omentum and the greater omentum of it as well. Technically, mesentery is the stuff into the small intestine, and each part will have its own mesentery named after itself. But that's technicalities that don't really matter. I have some pictures that come up in a sec, but hopefully this will do for now. Okay, so due to the dorsal and ventral mesentery in the foregut, it's subdivided by the stomach. and will become the greater and lesser omentum respectively. So the dorsal becomes the greater and the ventral becomes the lesser. How that specifically happens, I will also talk about in a sec later, but it all kind of happens at the same time, so it's a bit messy. So the greater omentum is also perhaps termed as an apron, and is attached to the greater curvature of the stomach, which is sort of the larger side. So this side here, when you're looking at a stomach, that sort of is a good diagram at all. It's composed partially of gastrophrenic, gastrosplenic, and gastrocolic ligaments. The lesser omentum is basically connecting the liver to the stomach. It's effectively all it does. And it's also composed of these other two ligaments. Ligaments in this case is just mesentery that's like by itself, effectively. There are no like ligaments that you might have seen last year in the upper lower limb just hanging out in your abdomen. It doesn't work. This separates what becomes the omental bursa, the lesser sac, and the greater sac. And I'll touch on those a little bit more later. So yeah, like I said, ligaments are just double folding the peritoneum, and they effectively just separate things out. There's not too much point there. Okay, so the foregut viscera initially develops in a straight line, i.e. it's a straight line between the things. Hold up. Where was it? Sorry. Okay, straight line from the spleen, even though it doesn't include in the gut tube. And this is kind of the diagram I'm looking at here. Pretend this one here. So it's a straight line to begin with. Okay, so from the anterior abdominal wall to the liver is the falciform ligament, as just a point. From the liver to the stomach is the mesenteric omentum, or more specifically the hepatic gastric ligament. And then the spleen that connects the dorsal mesentery to a part connected to the stomach. Okay, so the foregut, how it develops is due entirely to the liver. And hopefully Professor Lazarus did that like dance thing with you guys still, where she kind of gets people to dress up and embarrasses themselves. But effectively, the liver will grow and force everything else to rotate away from it as it takes up too much space. So the liver will rotate right as it grows towards the right and will therefore pull everything else to the left as it kind of develops into the ventral mesentery, and all the other structures sort of just run out of room. Yeah, because it goes so fast, the barrier of the liver is due to the liver going through the peritoneum, and there will be no, I guess, peritoneum covered in that specific area of the liver, which is why it's called the barrier area. As a fun fact, apparently that's why you get stitches, because of this area rubbing against the diaphragm. Fun fact. Okay, so due to this rotation, the once equally sized two sacs change. So this was originally the same size. As you can sort of imagine, if this was a straight line, these two sacs, so this lesser and this greater sac, was the same size. But as it kind of rotates, this kind of rotates towards it, it kind of shrinks this lesser or omental bursa to become this lesser sac and smaller, whereas this greater sac takes up much more space and gives given much more space. As this kind of happens, the dorsal mesentery then flop over and will look like an apron, as it's classically seen. It doesn't actually look like that in real life, partially because the greater omentum has an immune role and will wall off infections. And this happens severely. It can actually include blood vessels, but I've never heard about it in actual clinical, like, at all. So I don't know how relevant that is. But it can move around and wall off infections. It also won't look like that, or it wouldn't have looked like that in specimens anyway, or in your cadavers anyway, just because of like the process in terms of how they get preserved. But more importantly, they have immune roles. As a result of this rotation, the final position of the stomach is very variable. But generally speaking, a lot of these things in the abdomen will be very variable in their final location. And that's kind of an important thing to realize and important to appreciate. This last point, I don't know how clinically relevant it is, but again, this is more of a thing for your exams. If it's a pancreatic problem, we'll generally go into the lesser sac, and a gastric problem will escalate into the greater sac, just because of where the structures are located in relation to the lesser and the greater sacs. And this is sort of the diagram that I'm talking about. So this grows left, like I showed, and is making this lesser omentum much smaller than this greater omentum here. If you can imagine, this also kind of goes towards the bottom as well, as you can kind of see here. This is the lesser, and it's kind of contained, whereas it's the whole area in front is sort of greater bursa here.
think also just, wait, sorry, if you go back, just to orientate you guys, that blue bit would be where your spine is, right? So the bottom is anterior, and so the liver is actually, it looks to your left, but it's the patient right. And when you're looking at CT scans and things like that, you have to imagine yourself kind of, say, looking at their feet up. And this is the view that you would get.
Yeah. As a tip for CTs, the way I imagine it always is like put your right hand like across your body and the left hand across your body, and that's the right orientation. Is how I see it. I don't know if that helps anyone, but it helps me. Okay, so continuing with the foregut with now the pancreas. So the pancreas starts out as two buds. I don't have a picture of two buds. That's kind of bad. But effectively, imagine another bud. It's kind of out here or out here. Okay, the larger dorsal and the smaller ventral bud. As the liver sort of does its thing again, the pancreatic buds will rotate, leaving the dorsal bud pointing to the center, as in points to the center. Thus, this means the ventral bud needs to twist more to meet up with it, because if you imagine there's a bud here, it needs to kind of take and hold the whole 360 to get there. Imagine here. To do that, it will reach first this layer of dorsal mesentery, or this mesenteric layer. And for it to get to here, there's no real way for that to happen. And so what it does is instead it kind of breaks through these layers of mesentery and will therefore fuse. This means that this back posterior layer of mesentery is lost, and therefore the pancreas will become secondarily peritoneal. This excludes the tip, which stays intraperitoneal, just because I guess it's not close enough. This is shown by the superior mesenteric artery, so the SMA, passing underneath the neck of the pancreas, but above the uncinate process, which is where the ventral bud ends up becoming. Problem with this can cause things such as the annular pancreas, which is kind of just like where the pancreas sort of wraps around the duodenum and constricts it. Beyond that, nothing too interesting there. So like I said, as a visual thing, imagine there's a little bud here, it moves across, and then it will rotate across into touching here. So this probably is better. It comes across here, and then it will touch here. Hopefully you can see my cursor, because if it can't, then this doesn't help. Okay, so moving on to the midgut. So the midgut will also rotate, but this rotation won't be caused by the liver because of retention bands. So these retention bands are important, but just keep in mind for now, the superior retention band is called ligament of Treitz. It's from the duodenum to the diaphragm. The inferior retention band is a phrenic-colic ligament. Both of these bands are important. The inferior one is because it's how you separate sort of the lower gut from the midgut. And it's kind of where the vagus nerve later and its sort of innervations will change. But we'll talk about it in a second. So the midgut will rotate around the superior mesenteric artery. So what happens initially is it forms a loop with a cranial and caudal limb. So cranial and caudal limb. So what will happen is it will go sort of through into the umbilicus because there's basically just not enough space. And it's connected to this thing called a vitellointestinal duct. I don't know how useful that is or important that is, but basically it herniates into the umbilicus with this kind of loopy structure. As they kind of grow and develop, the cranial limb becomes, or is developing faster and will become heavier. And this will be the first 90 degrees counterclockwise turn around the SMA. Give a chat.
That was just me.
Cool. Yeah, easy. Okay, sorry. So yeah, it's kind of rotates around the SMA. This is kind of an important point, just because they kind of ask it. It's kind of annoying, but it is a thing. This is the first rotation of 3, which makes a net 270 degrees of counterclockwise rotation. Again, I just put that there because they assess it. I don't know how important or useful that is. So as the cranial limb becomes a small intestine, it becomes a formed loop. So it does this thing here where it forms this sort of loopy thing. The caudal limb, which becomes eventually the colon, will develop this cecal diverticulum, this little bump, basically. As it grows, the cranial limb will come back first and come under the caudal limb. So this orange bit comes in first and will bring with it the caudal, or the green one, as it kind of comes back. That process means that the duodenum goes behind the transverse colon, and these will form the second and the third rotations that I'm talking about. The ascending colon will later develop as it comes down and move through. This basically means that the appendix can be on any layer or any point along this line. Very commonly, or most of the time, it's down here, but this will push down with the colon of the appendix and it will just grow downwards until it's in a normal position in this area here, in the right lower quadrant. My Siri just turned on because of that.
The way I remember it is that, like, you've got this top limb that is growing much more rapidly than the bottom limb, right? So it's all protruding out, and then the top one's growing much faster. So it gets heavy and it like flops over. And that's the first 180-degree rotation. And then as it's coming back, it just twists a little more and you get the last 90 degrees to get like the full 270.
Yeah, effectively, that's kind of how it works. So just imagine this thing gets heavier, as Lena said, and it just kind of pushes down and then pushes back. That's effectively what you're witnessing through this whole process. As this kind of happens, the ascending and descending columns will push against the posterior abdominal wall and they will lose their posterior mesentery. And they will come secondarily retroperitoneal. The second and third parts of the duodenum will also do that same thing. Problems can happen when the vitello-intestinal duct fails to obliterate and it can wrap around, do all kind of random things. I think that's more of a fun fact than important, but it can cause a volvulus, which blocks things off. I'm not sure if this is the same video that Alina linked into the chat, but this is also, I think, a really good video to explain the process. So just, if they're not the same video, give both a watch. If they are, then it's double promotion.
Give it a watch. It is really good. I watched it like 10 times to learn this stuff.
Yeah, it's effectively how you learn, basically. Okay, next diagrams. So this is kind of more midgut, but not really. It's more about the omentum. So as the midgut kind of goes back into the abdomen, the omentum will develop inferiorly. It will come down, the greater omentum. This means that the ascending, descending and descending columns can be seen next to it, as in next to this omentum bursa, and won't be covered by it too much. But it also traps the transverse column, keeping it intraperitoneal as it kind of moves through. If you want to think about it, effectively, the greater omentum will have 4 layers because these are all 2-layered kind of segments, and this will end up being 4-layered, but that's kind of like a redundant or useless point. But it's a thing you can recognize and understand. Okay, so hindgut's a lot easier and a lot simpler to recognize. Effectively, the hindgut has this one tube called a cloaca, which is what birds have apparently, which is basically a urethra and a rectum in one. And it's separated by a wave of ectoderm. And the point where it finishes is called the perineal body or the perineum, splitting the urogenitals from the rectum. That term itself is more important next semester, but effectively just think of it as the bit of flesh, I guess, between the genitals and the rectum. If this doesn't occur, you get a connection between the bladder and the rectum or the vagina and the females. As this sort of pushes through, kind of you have the same sort of pushing through on the other side to try and get them to meet. So you get endoderm pushing downwards and ectoderm pushing up to sort of meet those two processes. If this fails, you basically just get either anal stenosis, which is basically like a little hole, or a persistent anal membrane, otherwise known as an imperforate anus, which is basically just got stuff in between. The point which these things meet is called the pectinate line. That's really important. The structures in terms of how they're innervated and how they're supplied are different above and below the pectinate line. But the point basically here for now is that above it is a rectum and below it is the anus. So they're actually 2 different things. I'll talk about those a little bit more in a sec when I talk about basically every organ a little bit more. But this is kind of the diagram we're looking at. Not too exciting. It's just one hole that becomes 2 holes. That's effectively what you think about. Okay. So this is a table. Hopefully you have something like this already, but this is, if you don't, this is basically the table that we're looking at. Okay, any questions from that? Spam the chat now if you have anything. And hopefully someone will see it. Okay, so there are also 2 ways, all these 2 ways that I think that the gastrointestinal can be described. And this is the foregut, midgut, hindgut, which is kind of from the embryology that we just talked about. giving the innervations the interior arterial distributions, as well as the upper and lower gastrointestinal tracts, which is divided by that ligament of Treitz, which I was talking about earlier, which is the superior retention band. Occurs with the hepatoduodenal flexure. In terms of the division of the foregut, midgut, and hindgut, this is also very important. So foregut goes from the mouth to the hepatopancreatic duct in the duodenum. The midgut goes from the hepatopancreatic duct to 1/3 of the distal transverse colon, so 2/3 of the way down the transverse colon. And then the hindgut is just the rest, from the 2/3 down to the rectum. These are important. So this is important for arterial innervations that I'll talk about in a second. And this is important for clinically differentiating between upper GI and lower GI bleeds, at least for you guys for now. So black indicates an upper GI bleed because it's had more time to go through. Red and bright red is more of a lower GI bleed because it hasn't had enough time to digest it effectively. Okay, so sympathetic innervation. So all sympathetic nerves going to, well, actually all sympathetic nerves in general go from T1 to L3. So they come from those areas. This means that if you want sympathetic innervation somewhere else, you need to have, I guess, a way to get there. And this is done by a series of ganglia that exist on each other's sides. The ganglia are just like little bodies of cell bodies. And they will enter through a white rami communicans and either synapse at the paravertebral ganglion, so these side ganglions, or they will extend to a paravertebral, they'll either go up or below and then synapse there as well. So what I mean by that is you follow this red line, they will either go through and synapse this ganglion here, and then this line goes to the grey rami communicans and does its normal thing that we talked about in the first year. You guys will talk about in the first year. Or it can go through and kind of go up or down to these other bodies and then kind of leave that way. This part we'll talk about in a sec later. In terms of parasympathetic information, all parasympathetic information will come from cranial nerves in the region of S2 to S4. Could you hear me before? I'm assuming yes. This is called craniosacral outflow because it's the cranial and the sacral outflow. Cool. So this is sort of the diagram. So innervation of GIT. So innervation of GIT is all autonomic and comprises of sympathetic and parasympathetic components. There are visceral bits and pieces that are for unconscious sensations, and they run with the parasympathetic nerves. So off the spinal cord come the splanchnic nerves, and they do not synapse at the paravertebral ganglia. So what we were talking about earlier is these kind of nerves here. They kind of go up and below. They synapse the paravertebral ganglia. These splanchnic nerves, they don't. So hopefully you can read my atrocious handwriting, but that's a splanchnic nerve. So they will go through and they won't synapse here, and they will synapse later at a prevertebral ganglion. This is what I'm going to talk about now. So this prevertebral ganglion are the celiac ganglion, the superior mesenteric ganglion, and the other intermesenteric, inferior mesenteric, etc., ganglia. Luckily, they kind of match up with your arteries. So the greater splanchnic nerves will arise from T5 and T9. The lesser splanchnics will go from T10 and T11, and the sacral splanchnics will go from S2 and S3. And then there's also a least splanchnic going from T12. These go to the kidneys and synapse the aortico-renal ganglia, which is not relevant or useful really for us at run ground. But these three are the important ones we need to talk about. And these kind of contributions are also important if you remember. So there's something to learn. Once they synapse at the ganglion, they will then travel through periarterial plexuses on the celiac trunk, the SMA, and the IMA. So basically, there are these little nerve things along these arteries. And this is kind of what this squiggly line is supposed to show or demonstrate. The parasympathetic innervation is much simpler. So parasympathetic innervation to the GIT comes from the vagus nerve, it's a cranial nerve 10, and the pelvic splanchnic nerves from S2 to S4. They do not meet the ganglia, rather they synapse directly at the organ. So this is a different kind of character, and that's kind of the big deal difference. These are different regions that you know differently. So the parasympathetics above the splenic flexure will be supplied by the vagus nerve, whereas after it will be from the pelvic splanchnic nerves. In terms of how to remember, it's the pelvic splanchnic, the pelvic splanchnic, and not like the least or something like that. You can remember it from thinking P to P, so parasympathetic pelvic. That's kind of a way to talk about it. In terms of where these will supply simply the areas that they are kind of talking about. So if it's on the celiac trunk, it will go to the organs supplied by celiac trunk vascularly wise. This is a nicer diagram of that sort of picture. It's kind of complicated to look at, but it's sort of the better thing that Lazarus may have got you guys to draw. I guess, I don't know if you got you to draw it this year because you didn't have a active learning, but this is something she would have got you to draw, and it's something to really remember and to recognize.
We've just got a question, Kevin.
Yep.
So Kelly's asking whether splanchnic nerves go through grey rami communicans when they move away from the sympathetic ganglia to the para-aortic ones. And the answer to that is no. So what happens is you get the preganglionic nerve. There's a preganglionic, and then there's synapse at the ganglion, and then there's a postganglionic, right? So the preganglionic ones for your splanchnic nerves, it goes straight from your spinal cord through the white, in all the way past that sympathetic trunk into your ganglia, which are in your abdomen, kind of by your aorta. And then that's where they synapse at the prevertebral or prevertebral ganglion to the postganglionic, which then travels along the blood vessel. Does that make sense? So the grey rami is when you want to like go back into the nerves at the back.
Yeah, so when you leave, it kind of like goes through the grey rami communicans. This is kind of like another way out, effectively. The splanchnic nerve is just a separate way out. There's only ever two nerves, a prevertebral and a postvertebral. So it won't kind of like leave here and come back here. That's what makes sense.
I think it's pretty difficult to understand, but like if you look at a couple more pictures, essentially you have to get into your trunk to travel between levels, and that's why things would travel in and out.
Yeah, so it's like termed as an elevator sometimes. There's like an analogy or whatever to go up or down rather than anything else. Oh, cool. Hopefully that makes sense. Feel free to keep asking questions, and if it didn't make sense, ask it again. Okay, so the vascular supply of the GIT. So celiac trunk. So the celiac trunk, like I said before, comes from T12 and will supply the stomach, the pancreas, and parts of the duodenum. So the celiac trunk will leave the aorta for like about 1 centimeter before it goes into 3 major branches, and these are very important. So left gastric artery, the splenic artery, and then the common hepatic artery afterwards. So the left gastric artery will go left and travels along the lesser curvature of the stomach. This is kind of the smallest of the 3, but this is kind of just the thing. It anastomoses with the great right gastric artery, which I'll talk about later. The splenic artery travels to the left towards the spleen, as you'd expect, and has a tortuous course. That's a kind of a buzzword. It means squiggly. It does this kind of like squiggly route. That means what I mean by tortuous. That's the splenic artery. So it runs posterior to the stomach, and that's kind of important because if an ulcer happens, it can erode into the splenic artery and cause bleeding. And then these are branches of the splenic artery. So the gastroepiploic, also known as the gastromental, will supply the greater curvature of the stomach and will also anastomose with the right gastroepiploic artery, which I'll also talk about in a sec. The short gastrics are about 5 to 7 arteries that occur at the end of the splenic artery. They're kind of not really important. I think they're basically like these ones basically here. They supply the fundus of the stomach, which I'll also talk about later. The pancreatic branches, there are a lot, but they're not very important. So these travel inferior and posterior to the pancreas, and they're basically just like here. There's a transverse one, there's a transverse pancreatic artery here and the posterior pancreatic here, and they sort of just do their thing to supply the pancreas. Beyond that, not very important. The common hepatic artery,
There's a question just about the previous stuff with the sympathetics. The question is sacral splanchnic the same as lumbar splanchnic? And I think the naming of that just depends on like what level they come out at.
Yeah.
So the sacral splanchnics arise lower down in the sacral region. And that they're are they still sympathetic? Sacral splanchnics? They are, aren't they?
Pretty sure they are. So effectively, like in terms of like naming sacral splanchnics as these, they've termed them lumbar splanchnics. Which, I'm gonna be honest, I don't really know, but I just was looking at a picture. But effectively, they should come from a bit lower down and work through that way. So I think there's the same sort of idea in this kind of image here, but I will have to look that up later.
Yeah, I think we should double check that because
so
sacral is usually PNS.
So does sacral splanchnic come out at L1, L3, but travel down the chain and come out at the sacrum?
What's the question? I think they're different.
Yeah. The answer to that is yes. So if you go back to the picture, Kevin.
Oops. There we go.
I think the idea is that the sacral splanchnics, they emerge from the spinal cord at like the lumbar region, so they're still sympathetic, but then they descend into the sacral region and then emerge, and so that's why they're sacral splanchnics. But they are still sympathetic because their fibers come from the lumbar region.
Yes.
Does that make sense? And then I think your lumbar splanchnics, they just come straight out at the lumbar level. Any mnemonics or tips for remembering all of these nerves, etc.?
As in these nerves?
Yeah, I think so.
So these ones, I mean,
It's
the way I
tricky.
remembered it was that they kind of go like straight one after each other. So the greater, lesser, and then the least are from T5. So if you remember the start, T5 to T9, that's kind of the only ones important. And then the other ones are 2. So 2, T11, T10 to T11, and there's 1 and T12, the least. And then after that is the sacral splanchnic 2 and S3. That's kind of how I
Yeah, so it makes sense that the greater splanchnic would have like the most contributing, so 4. And then after that, it like halves every time. That's how I remembered it. So it goes from 4 to 2 for the lesser splanchnic to 1 for the least splanchnic. And then they run in order, T5 to T9, T10, 11, T12. Yeah. That I think is the easiest way, but I don't know. And then I don't know why it skips S1 either.
Yeah, that one is just like the classic thing of like you have to learn the exception. But yeah, hopefully that helps. Okay, where was that to? Okay, so the pancreatic branches, blah, blah. Okay, so the next one is the common hepatic artery. So this is only one of the 3 arteries travel to the right rather than to the left, and it will pass the duodenum and divide into the proper hepatic and the gastroduodenal arteries. So the proper hepatic, if you look at this picture quickly here, is this one here, and the gastroduodenal is the one that comes below. I have a better picture coming up, but this is just for now. The right gastric artery will come off the proper hepatic and will supply the pylorus and the other side of the lesser curvature, so this will connect to the left gastric. The right and left hepatic arteries will supply the liver, so these ones here, and the cystic artery. So normally the cystic artery will come off the right hepatic, but there are variations to that point. And it will normally come in a space called Cowlitz triangle, or the cystohepatic triangle, between the common hepatic duct, the cystic duct, and the inferior surface of the liver. So these little triangles here, which will be formed by this, the liver border when there was a liver there. There's a lot of variation that come with that, and that's kind of all it's put in there. And then the branches of the common hepatic continue. So the gastroduodenal sends posterior to duodenum. Important because if a duodenal ulcer goes through, it can bleed into the gastroduodenal artery. The right gastropolyp supplies the greater curvature of the stomach, and the superior pancreatic duodenal branch, which is kind of like the one that no one really cares about, just goes down and supplies the gastroduodenal. And then anastomoses with the inferior pancreatic duodenal artery forms on the SMA later. This is the better diagrams of it. If you think about it, there's a stomach in here, which is this kind of gap that goes through. And this is sort of the diagram that I would basically learn from this left, and this is one I did learn. These arteries here, you can kind of disregard a lot of the time, but these ones here, so the left gastropolic/gastromental, the right gastropolic/gastromental are important, and this right gastric artery that comes after it bifurcates into proper hepatic is also important as well. This is just a better diagram of the pancreatic supply, but equally not super relevant. This is the one that I would learn more so. Okay, so the vascular supply of the SMA. So this arises from the level of L1, supplying mid-gut structures. I guess think of it, the way I thought of it was a right side and the left side. This is not actually how they look in real life, it's just how I drew it in a diagram. So keep that in mind. But the right group, to me, supplies the colon, the head of the pancreas, and the left supplies the jejunum and the ileum. So the right group has the acronym MRI. Just ignore the inferior pancreatic jejunal just because it's not that important. That will go up to superior pancreatic jejunal. But the middle colic is a branch that will form the marginal artery with the left colic, and it will supply the colon. The right colic supplies the ascending colon, and the ileocolic will supply the terminal branch, or the terminal branch supplying the ileum, cecum, and the ascending colon. There's also an appendicular artery supplying the appendix, but that's like a tiny little shrivelly thing that comes there. But it has the acronym MRI in order of kind of how high up it is. And the left group is the jejunal and the ileal branches supplying the jejunum and ileum respectively. They kind of are just sort of random in terms of like where they are, so it's sort of not important to know specifically kind of like what's going on there. But these will pass through the mesenteric to form anatomic arcades, which are this kind of this stuff here, and then vasa recta, which are these straight arteries that come off it. Jejunal branches will have less arcades but have longer vasa recta, and ileal branches will have more arcades and shorter vasa recta. So just learn the one, and then the opposite is for the ileal or the jejunal, depending on which one you've learned. The SMA crosses over the left renal vein as it travels from the left kidney towards the IVC near its insertion. And this is termed nutcracker syndrome. And basically the idea is this space is compressed, i.e. the SMA or the aorta behind it with a renal vein in the middle. If that kind of compresses it, that can block the arterial supply or the venous drainage, causing back pressure into the kidney as it sort of builds up. The SMA also crosses over the third part of the duodenum, and sometimes that can be relevant as well. But most of the time, the more important idea is this kind of nutcracker syndrome. This is sort of the thing that might quiz you on like a imaging slide more than anything. But this is kind of what I meant. So this is the longer vasa recta, or the shorter vasa recta.
I don't know if it helps anyone, but my anatomy tutor, like the way that he told us to remember it was that jejunum sounds more like giraffe, and giraffes have long necks, so they have long vasa recta. And there's also like another fact about ileum versus jejunum, which is that the jejunum has less fat around it, and then the ileum has more fat around it. So then the idea is that, you know, that Madagascar duo with like the giraffe and the hippo, I can't even remember what they're called now. Gloria is the hippo. But the idea is the jejunum is the giraffe, long vasa recta, and then the ileum is the hippo, it's fat, so there's a lot of fat. It's a bit of a weird one, bit of a stretch, but it helped me. So.
Yeah, I remembered it another way, in that the jejunum is like closer, right? It's more upper, and so you don't need as many arcades, because you only get the vasa recta when you're pretty close to the intestines. What brings it there are the arcades, and that's why the ileum, which is further away, you need more and more arcades, and it just keeps doing these loops until it reaches, because it's further away, and that's why you have more arcades in the ileum.
Cool. So hopefully one of those two methods helps over my just like learn it brute force, but hopefully it helps. So this is the branch of the SMA that I was talking about, to the MRI sort of kind of orientation kind of thing. All right, so the last one, the last major artery is the IMA. So this comes from L3 and supplies hindgut structures. Effectively, there's So like 3 arteries. The left colic artery, which will help form the marginal artery as well. The sigmoid artery, as it kind of just comes down. There's quite a few of these, just they randomly happen. So these are just the sigmoid. And then the superior rectal. So they descend into the pelvis, forming the walls of the rectum, and will communicate with the middle and inferior rectal arteries, which will be talked about in probably a later presentation and not today. Probably later in the next semester, but yeah.
Kevin, you just cut out.
Did I cut out?
For a bit.
Yeah, okay. So am I back now? Cool. So there's 3 arteries. So left colic, sigmoid, and superior rectal. Left colic is an important one, forms marginal artery with the right colic. Sigmoid is just a couple of branches that goes to the sigmoid colon, and then the superior rectal will go down to the rectum and communicate with the middle and inferior rectal artery there. And this is kind of the diagram of the whole thing.
Yeah, I think it's important to note that the superior rectal, that supplies above the pectinate line. And so if you had to remember one, remember that one. Yeah.
Then I'll talk about that in a little bit more detail in a sec. But the fact that there's a middle and inferior and where they come from, you can ignore for now a little bit. This is kind of a bigger, more overall diagram of the whole thing with a marginal artery that you can actually see rather than in chunks. But beyond that, it just is what it is. Okay, so the venous
makes a lot of sense too, the whole arterial supply of the colon, because like the SMA does sort of the whole like right side, and then the IMA does like the whole left side, and it just sort of makes sense that like you've got the like middle and the right and the ileocolic. The naming sort of comes from like where it goes. So ileocolic is going to supply the like ileocecal junction, right, where the ileum becomes like or meets with the colon. And then your right colic is just going to go straight to the right. So it's going to supply the ascending colon. And then you've got like the middle colic, which will sort of do a little bit of transverse because it's like the middle area. And then your IMA, you've got like the left colic, which obviously goes straight to the left. So it does the descending. Sigmoid, as the name suggests, does the sigmoid. And then the superior rectal, it's called the superior because there's 2 rectal arteries. So this one's coming from above. And then you've got the inferior rectal coming from below. And that's obviously going to go supply the rectum. So the naming in this area makes a lot of sense if you think about it just like positionally.
Yeah, like think about where they are and where they go. That will generally help you with understanding if you're struggling. Okay. All right, so in terms of venous drainage of the GIT, so systemic, there's 2 kinds of major draining systems. So the systemic system, and then there's the portal system. So I'll talk about the portal system in a sec. But the systemic system will go through the IVC, which punches through the cable hiatus at level T8, positioned to the right of the abdominal aorta. And these tributaries are all these sort of veins. The hepatic vein will drain the liver, and it's kind of like the big one, I guess. And then there's a whole bunch of these. The renal vein will drain both kidneys, but only the left adrenal gland, the left testes and ovaries. So the left renal vein, not obviously the right one. So the SMA will also cross over the left renal vein. This is sort of an important fact because varicoceles, so enlargement of the veins in the scrotum basically, are more common on the left as the renal vein does not have proper valves, which increases the pressure, and also a reason why the left testes tend to lie lower, is a fact. In terms of the right testicle and the ovarian veins, they're just separate veins which go into the IVC themselves, and that's kind of like how the other ones drain. That sort of makes sense. And then there's suprarenal, right suprarenal veins, and the inferior phrenic vein which drains the diaphragm. But the important ones, really speaking, the renal vein to understand, and the common iliacs because it's just big. In terms of, and this is kind of like a diagram. So the right goes through, whereas the left goes into the renal vein quite directly. Cool. So the venous drainage of the portal system, is basically how all of the nutrients absorbed into the blood from the digestive system is processed as it's processed in the liver. So it'll all go via the portal vein, entering at the porta hepatis, which is the hepatic artery in the bile duct, basically. It's formed by the splenic vein and the superior mesenteric vein, but has contributions from all these kind of other random things. So splenic vein is a straight vessel from the spleen traveling posterior to the pancreas. So it goes straight, and it's not tortuous, it's straight. And it joins the superior mesenteric vein, the level at the neck of the pancreas. into the splenic vein will go the inferior mesenteric vein, alongside others. The inferior mesenteric is a kind of important one, and that will drain its own set of things. What it drains isn't that important, but it's also kind of like in its name. So what's supplied by the inferior mesenteric artery will probably be drained by the inferior mesenteric vein as well. It kind of makes sense in that regard. The superior mesenteric vein will then drains blood from the small intestine, and they will connect to go into the portal vein. So superior mesenteric vein, splenic vein connects to become the portal vein up here. This was also something called a portal poodle. It was kind of I guess a fun way to memorize it. This is kind of like the head. This is the foreleg, this is the hind leg, this is the tail, this is the body, if you want to remember it that way as well. This is I guess, less diagrammatic view of it. Hey, Gavin's here. This is sort of, and this is sort of a way to kind of visualize it as it kind of goes through. Importantly, there are connections between the portal and the system and the systemic systems, and this is important when pressure builds and portal hypertension happens, which can happen because of cirrhosis of the liver, as it sort of kind of degrades and kind of becomes less able to sort of take all that blood through. So the major sites and the important ones you want to think about are the left gastric vein and the esophageal veins. These can cause esophageal varices, and rupture of these can cause massive upper GI bleeds that are fatal unless treated very quickly, and even then, not good. And the second one is between the superior rectal vein and the inferior middle rectal veins. So the systemic system there. And these can cause hemorrhoids, which can bleed when a rupture. These aren't anywhere near as bad, as in they won't kill you. They are just, I guess, embarrassing to have when you're just bleeding out your butt. But beyond that, they're not the worst. I guess if you want to think about it, if this ever comes up in a question, they'll give you clues in terms of why they're cirrhotic. So alcoholics are probably your buzzword in this case, or they have hepatitis. That's really two buzzwords. Other sites that can happen is the anterior abdominal wall. So this is between the paraumbilical veins and the epigastric veins in the interior abdominal wall. And these present as caput medusae. So hopefully you guys still have clin skills lessons, and maybe one of the things you got told to look for was caput medusae or veins. This is kind of what it is and why it happens. You also get an inferior abdominal wall between the colic veins and the retroperitoneal veins. And then the other ones, which is the mental and retroperitoneal veins, and ductus venosus and the IVC, which kind of are there. But these two are the really important ones that kind of exist, and these two are also sort of important. But overall, there are 6, basically. Okay, so the biliary tree. So this is, so bile is synthesized in the liver, and it's stored in the gallbladder, and they are very separate areas. So it's kind of how they get there. So from the liver, they get drained into the right and left hepatic ducts before they form the common hepatic duct. So the common hepatic duct, I want to say right and left hepatic ducts. Could be the other way around, doesn't really matter. And this will form the cystic duct. So, and this is joined by a cystic duct that comes from the gallbladder. So this area here, to form the common bile duct. This will pass posterior to the first part of the duodenum and the head of the pancreas. So it will first connect to the pancreatic duct here, and the pancreas will be like this kind of big area in here. And that will lead to the hepatopancreatic ampulla, also known as the ampulla of Vata, and enters the descending duodenum, the second part of the duodenum, by the major duodenal papilla, located in the posterior medial wall. These bolded terms are kind of important as buzzwords. There's also a minor one coming from an accessory pancreatic duct, coming from the pancreatic duct, but this is less important. Just know it exists. Sort of thing. Okay, so general GIT histology principles, and I'm going through these principles because in a sec I'm going to go through every organ there is and touch on them to some extent. So when viewed histologically, there's a mucosa, which has got the epithelium, the lamina propria, which includes the mucosal glands, the blood and lymphatic vessels and lymphatic tissue, and the muscularized mucosa. Then there's a submucosa, which contains dense, irregular connective tissue and blood and lymphatic vessels, and the submucosal nerve plexus. Then you have the muscularis externa, which depending on where it is, realistically actually has different things, but has a circular smooth muscle inner and a longitudinal muscle outer. This is important. The way I sort of memorize that is in the colon, there are these long sort of tania coli, which are these long muscular lines which go through the whole of the colon, and they are, you can see them, so therefore the outer, and then the inner ones are just the ones that are inner from that. The stomach has another layer, but we'll touch upon that in a second. And the mesenteric nerve plexus, which hopefully you learn in phys and we'll go through on Sunday, is between these layers. And then there's the serosa adventitia.
Sorry, just to help remember which one's inner and which one's outer, if you think about peristalsis, right, it's kind of squishing it along like that. And you wouldn't want your circular smooth muscle to squish like your longitudinal muscle. So it has to be on the outside. So the circular smooth muscle will go like this, and then the longitudinal muscle on the outside will be able to kind of like push it along like that. So it goes like this, if that makes sense.
Cool.
And just to clarify, the inner is like closer to the lumen, and then outer is not close to the lumen.
Cool. And then the adventitia is connective tissue with the tubus rectus the structure, and the serosa is a simple stone thing that surrounds it. So it's kind of like same, slightly different, but for you guys, it's basically the same. All right. So this is where I kind of talk about all of the different things in the abdomen by themselves and talk about it. Some of these things are kind of just like, what is its nerve supply, what is its arteries, that kind of stuff. And that's just there for your own purposes and for your own help to kind of help you guys. But some of these are kind of also just important. So we'll start with the esophagus, but I'll be skipping through these things because otherwise we'll be here all day. But this originates at the level of C6 and will descend through the superior mediastinum and goes through the esophageal hiatus at T10, because it has 10 letters, and terminates at T11. So there are 2 layers of muscle in the esophagus, and basically, the one you think to think about, the kind of important idea is that the superior third is a voluntary muscle, and the inferior third is smooth muscle, and therefore not voluntary. And the middle third is sort of like this mix of between. And it kind of makes sense. If you're saying at the top is striated and you can control it, and the bottom isn't, then the middle has to be some kind of mix hodgepodge of the two. That's kind of an important fact. There are 2 sphincters. There's an upper, which is an anatomical sphincter, which constricts to prevent entry of air, so literally like closes. And then there's a lower, a physiological sphincter, i.e. there's no real like anatomical structure there, which will close, it's created by the angle of the esophagus as it enters the stomach and compresses because of the right crus. That's important, I guess. There's also 3 main physiological constrictions, and this is very important because I can assess this. So the bronchus, the left main stem, and the arch of the aorta, so therefore sometimes you can maybe say there's 4 points. The cricopharyngeus muscle, or the cricocartilage, depending on what you read, and the esophageal hiatus. So if the sphincter, I guess, doesn't really work as well as it should. And these are 3 or 4 main constrictions that you really want to know. It's innervated by the esophageal plexus. It's got more stuff than that, but that's all you need to know. It's got this vascular supply and this venous supply, venous drainage, sorry. Again, I've given it to you, but like, just have a look at it. Histologically, it's aligned with stratified squamous epithelium. Importantly, in Barrett's esophagus, these cells will change to simple columnar due to the acid irritation, and then all become metaplastic and change. So this is like your classic knowledge of, I guess, the metaplasia that occurs. So different cells become something else. It comes back in 3rd year with the right old vengeance. So just know that, I guess, is a fundamental point. It becomes simple columnar because the stomach is lined by simple columnar. And basically, you want to think about it, it mimics a little bit more the stomach's normal structure. Okay, so the stomach's gross anatomy. So it's divided as an intraperitoneal organ in the epigastric and umbilical regions. It's got 4 main parts: the cardia, the fundus, the body, and the pylorus. Sometimes you can also think about it as having an antrum. So if it has an antrum, this line that I'm drawing with my cursor is where the antrum will begin, and the red ending where the red pylorus begins. So sometimes that's the thing that can happen as well. Important a little bit more next year, if I'm being honest. The stomach also has two curves, so the greater and lesser curvature. So if you were wondering what the heck I was talking about with two curvatures earlier, that's what I meant. And they have different connection points to it. There are also gastric folds within them called rugae. So that's kind of why the inside of the stomach looks so bumpy. And it's there so it can expand and will smooth out when the stomach expands to meet the demand of eating, basically. So this kind of bumpy layer. Do I talk about it in a sec? So there's also another layer within the kind of stomach. So there's three muscle layers. So the longitudinal muscle layer, there's a circular muscle layer, and there's also an oblique muscle layer in the stomach as well. So there's kind of three layers, three muscular layers in the stomach instead of the two that we normally see. That's kind of just the thing. And the pyloric antrum we talked about here. Cool. The innervation is from the vagus nerve, or parasympathetic innervation from the vagus nerve, and the sympathetic is from the celiac plexus, from the greater splanchnic nerves. The vascular is from left and right gastric, and the right and left gastroeploic, and vice versa, really, for the venous drainage as well. Generally speaking, in terms of lymph node drainage, it goes in the gastric, eploic, the celiac nodes, and the periodic nodes. In terms of your knowledge of lymph nodes and how detailed that needs to be, the answer to that would be not very. But do know what goes superficial and what goes deep. So these ones are going to go deep, and that will be mostly superficial sufficient, when you're doing exams like that. Histologically, it's covered by simple columnar epithelium, and it contains gastric pits where there are parietal, chief, and goblet cells. We'll discuss in physiology a little bit more. But parietal is where your acid and your intrinsic factors are produced. Chief is where your enzymes are produced, and then goblet cells produce mucus.
I'm not sure if Kevin mentioned it, but I think in terms of just where the veins and arteries are, it's like gastroepithelial arteries and veins are along the greater curvature, and then the gastric ones are along the lesser curvature and the fundus.
Yeah.
Which is important.
Yeah, and it's kind of like what gives it that shape in that diagram that I showed earlier from that. Cool. Okay, duodenal gross anatomy. So there are four parts of the duodenum, and these are kind of important. So this first part is the superior part, intraperitoneal. It extends upwards from the stomach. The descending part is secondary retroperitoneal. The inferior part is also secondarily retroperitoneal. The second part contains the major duodenal papilla. That's sort of important as well. And the fourth part actually is an ascending part, and it's also secondarily retroperitoneal. So do know that. And that's kind of where the jejunal flexure is and where the suspensory muscle connects to it. So first part, second part, third part, fourth part, and this is a flexure.
And remember that second part is where the bile will drain into the duodenum. So the ampulla of Vata opens on that sort of medial side of the second part of the duodenum.
Yeah. And just in terms of the flexure, your ligament of Treitz is also that point, and that's where that's the division between your foregut and your midgut.
Sorry, the upper gut and the lower gut. The upper gut, foregut and midgut is from this papilla thing here.
Ah, my bad. Sorry.
All good. Anyway, so the innervation and the vascular supply, they are there. Yeah, I'm not really gonna read it, but effectively they are there for future purpose, like I said before. So if you're kind of lost in future preference where these kind of come from, you can just refer to these slides and you can find them quite quickly.
Yeah, don't learn it.
Yeah, I mean, you can remember it from kind of where they are in terms of foregut, midgut, and hindgut sort of thing. But I wouldn't stand there and sit there and learn this stuff.
Yeah, apart from maybe gastroduodenal, and that's because you're scared of the ulcer perforating onto it.
Yeah.
So it runs directly behind. Other than that, I doubt they're going to ask much about this.
Cool. All right, jejunum and ileum, they're both intraperitoneal. The jejunum begins at the duodenal flexure, and the ileum ends at the ileocecal. And there's no real anatomical location for where they sort of separate the two. They kind of just are different. At the junction between the ileocecum, there's a valve which prevents backflow going from cecum back to the ileum. There are also other differences. So the jejunum is generally speaking, is in the upper left-hand quadrant. There's a thick intestinal wall with more plicae circularis. So these kind of like folds. And the ileum will have less or no plicae circularis, not what I've typed there, as well as the shorter vasa recta and the more arcade we talked about earlier, as well as the thinner intestinal wall. Yeah. Again, the innervation, the vascular supply, the venous drainage, and lymphatic drainage that I'll talk about. In terms of histology, it's lined with simple columnar epithelium. There are also villi and microvilli here because it needs to absorb all of the nutrients that's been like processed basically, as well as crypts of Lieberkühn. But beyond that, I wouldn't put too much effort into learning that. In the duodenum, there are also Brunner's glands. In the ileum, there are also Peyer's patches. And these are gut-associated lymphatic tissue. Just know what they are. If they ask you what that is in the actual exam, I'm going to be real surprised. But just know they exist.
I think it's a common multiple choice like option though. Like are there Brunner's glands in the small intestine or something?
Oh, okay, yeah. Apart from that, they might give you, but like ask
Also,
them specifically what their purpose and stuff is.
Yeah, they'll ask you the location rather than
yeah, or what they do or anything like that. All right, so the large intestine or the colon. So the cecum is the first part, and it connects the ascending colon and the ileum. The cecum is intraperitoneal, and the appendix is attached to the cecum. And the final location of the appendix is quite variable, like we discussed earlier. The large intestine will go up as the ascending colon, and which will become secondary retroperitoneal. And as it ascends and it bends, it's either termed the right colic flexure or the hepatic flexure to become the transverse colon. And then when the transverse colon itself bends, it's either termed the left colic flexure or the splenic flexure. Again, the transverse colon can depend a lot where it is. It can actually droop a lot more than you think it might. So it doesn't always have to like look as aesthetic as it does in an anatomy diagram. It can droop quite far down and be quite confusing, but just keep that in mind. That's basically what I want to say there. The descending colon is secondarily retroperitoneal as well, as it becomes sigmoid colon. The sigmoid colon will continue to the rectum and makes an S shape, which is, I guess, kind of why it's called a sigmoid colon. Along the whole length of the colon, there are 3 strips known as the tenure coli, and these are kind of longitudinal muscle lines. There are 3 of them termed the free, which you can see, the mesocolic, which are attached to the mesentery or hidden by the mesentery, and the omental, which is connected to the greater omentum. And you also can't see. This will constrict to shrink the size of the haustra and circulations along the entire line of the colon. Along them, there are also these things called omental appendages. So if you ever wondered what those little fatty bits were called, that's that. And then beside them, there are also paracolic gutters where this is a space where fluid can build up. But these are much less important than the dependent locations from earlier. But they're also another site, basically. And a diagram for fun. This, again, is the innervation of the vascular supply. They sort of are just what they are. The venous drainage and the lymphatics. Histologically, they are lined by simple columnar epithelium. They also contain GALT as well as the crypts of Lieberkühn as well. Okay, the rectum. So this I will actually talk about a little bit more. So the rectum is a continuation of sigmoid colon, as we talked about in a sec, and the rectum is continuous into the anal canal. Its innervation is what it is. The inferior hypogastric plexus in the pelvic flanking nerves, sort of above the pectinate line. So the vascular supply is superior, is from the IMA, the middle is from the internal iliac, and the inferior is from the internal pudendal rectal arteries. And the venous drainage from superior, the middle, and the inferior, where the middle and inferior rectal arteries are systemic arteries, whereas superior is portal. The lymphatics, it drains the pararectal lymph nodes, which drains the inferior mesenteric. Just quickly look. And then the anal canal. So the anal canal is sort of what it continues into. So gross anatomy wise, it continues into the rectum, continues into the anal canal, and we have these little cushions which aren't really that important. But it contains an internal and external anal sphincter, which is important. So above the pectinate line is the inferior hypogastric plexus, so the same as the the rectum. And then below the pectinate line is the inferior anal nerves, the somatic supply. Again, the vascular supply, so below the pectinate line is the superior rectal branch, and the below is the inferior rectal branch. And then the venous, as we continue, superior rectal vein and the inferior rectal vein. And the lymphatic drainage is also different. Importantly, this is actually an important differentiation of lymphatics, where below is superficial, and so therefore that will be seen quicker by someone sort of looking at it or like trying to feel palpations like that, whereas the internal iliac from above the pectinate line will go undiscovered for a lot longer. And what I mean by that is like for a tumor to metastasize to these lymph nodes. So if a tumor goes into these lymph nodes, it will be hard to, or you can't feel them, and therefore it'll go undiagnosed for a much longer period of time. Whereas if it goes to superficial inguinal, you can feel them and it's nowhere near as bad as a result.
Yeah, so the two things they love to like hammer in with like the pectinate line is the lymphatic drainage and its application to cancer. So if you've got superficial drainage, they're palpable in the inguinal canal. If it's deep drainage, you're not going to be able to palpate it all the way up until it gets to the like supraclavicular nodes. And at that point, it's pretty late in the cancer development.
And
so
Virchow's node, it's in the left supraclavicular space, like there.
Yeah, and so it's the idea that like this is the first palpable node up here for any kind of like deep GI metastases. So that's always going to be a lot later in the tumor development. So those ones have worse prognosis, whereas something that's draining superficially and is going to be detected a lot earlier as like a mass in the inguinal canal has much better prognosis. And then the other point is with the innervation. So you've got somatic innervation below the pectinate line and then visceral innervation above. Visceral means that it's dull, it's poorly localized, and somatic means it's very localized and very sharp. So if you have hemorrhoids that are like perforating and bleeding above the pectinate line, they're generally painless or like minimally painful. And then if they're below the pectinate line, they're actually very, very painful. And so that's like one of the things that they might assess you on in like a multi-choice question. They'll say that someone's coming in with like very rectal bleeding. You know, it has to be a hemorrhoid that's below the pectinate line.
Cool. Hopefully that makes sense, because that's actually really important. Okay. Another point, I guess, is the histological features. So above it is columnar, so very similar to everything else. And then below is the keratinized stratified squares epithelium, so basically your skin. So it's kind of a differentiating point. Okay, the liver. So the liver lies in the right hypochondrium, so just the right area underneath your ribs, and it's covered by a capsule. There are a number of ligaments that attach to the liver, and these are the coronary ligaments, the triangular ligaments, lesser omentum, and the falciform ligaments. The coronary attaches to the superior surface, so these ones here. Yeah, these ones here. The triangular ligaments are the continuation of the coronary ligaments and is where the anterior and posterior folds meet. So the interior and posterior folds meet these triangular ligaments. The lesser omentum attaches the liver to the lesser curvature of the stomach by the patagiginal and hypogastric ligaments, which I don't have a picture of. And the falciform is off the anterior surface and will divide the interior or divide the liver into the anatomical right and left lobes, where the right is larger. So this is the falciform ligament, where the right lobe, yes, the right lobe is much larger than the left lobe here, even though it looks perspective-wise, makes it worse. Yeah, so off the free edge of the anterior surface is also the ligamentum teres, or the round ligament of the liver, and the halfway point becomes the ligamentum venosum. So that's another view below it, which we can't see here, but hopefully I'll have another picture talking about that. Okay, so the left and right lobes of the liver. So this is kind of an important thing to see. So anatomical divisions, they are divided into left and right lobe by the falciform ligament. So this ligament here. So this is the anatomical distribution of it, or division of it. This makes the right lobe much bigger than the left because the caudate and quadrate lobes are part of the right lobe. The caudate lobe is located more posteriorly, and the way I remember that was that caudate sounds like cord, so therefore it's closer to the spinal cord. The physiological division is defined by an imaginary line, I don't know the picture, from the IVC to the porta patis to the and the gallbladder. And this is known as the cantileal line. I remember it always the can't lie line because you can't lie about the division. It was a stupid thing in the class once, but it's stuck. Hopefully that is useful for you guys. And this makes the chorda and the quadrate into the physiological left liver. And it makes it, I guess, much more balanced, I guess, differentiation of the two surfaces. This liver can be further divided into the 8 segments called Canal, I can't say that word, cunoid segments. And the branches of the hepatic triad do not communicate between these lobes, which basically means that each of these lobes can be removed separately. So as you can see here, this one will go directly to this 5th lobe and will only go to the 5th lobe. And so therefore, if you removed just this lobe, it wouldn't really affect anything else in terms of vascular supply. So blood loss will still occur just because of the vertical nature of the hepatic veins, i.e. this, because of these happen, you'll still lose blood from this kind of process. The lobes separate transversely or branches of the portal triad, as in they're separated transversely like this. So this is the portal triad coming through, separating them transversely. Oops. And then, and they'll be separated kind of vertically by the umbilical, right portal fissures, and the down the center as a center. So they will left, right, and middle. So right, middle, left, with their respective veins in them as well. The chordae lobe is unique, and it's number 1, so the first lobe, I guess, as it has supply from both the right and left divisions of portal triad. As you can see here, as it divides, normally it only has 1, but it has both this chordae lobe, so it's 1 here. It's only useful really for questions. The umbilical vein, or the remnant of it, will divide in this area here in the left fissure, left portal fissure. Cool. The innervation is there. Again, it's not really that important. The vascular supply we talked about, and the venous supply, the venous drainage are important too, but beyond that, there's not really much to talk about there. Okay, histology. So the liver is made up of hepatocytes and is structured with what looks like hexagons, with the portal triad in the core and the central vein in the middle. Realistically speaking, whenever you're looking at them, just remember the iconic picture of this. Hopefully you've seen this, where this is a central vein, and these are the portal triad in the center, and this picture is kind of a hexagon, ideally. Technically, it's 3 of these hexagons structured around a singular portal triad, like as a technical point of how they're actually built. The portal triad describes the portal arteriole, the portal venule, and the bile ductal. And it's only the bile duct that drains away. And it kind of makes sense because otherwise, like, how's the bile going to get to like where it's supposed to be, right? So like the portal vein and the blood supply goes in the central vein, but everything else comes, or the bile, sorry, goes the other way. So like bile duct. The arteriole and venule will flow towards the central vein and convert into one vessel. And these are extremely leaky vessels. And the sinusoid. Outside the sinusoid is a space of DESI, which is the gap between the hepatocytes and the sinusoid. So this space here. So the hepatocytes and the sinusoid is a gap, and it's the space of DESI. How important that is, I don't know, but it's kind of just there for completion, but also just for you to know because it was talked about. Yeah. These pictures, I would heavily recommend remembering what they look like. I'm not sure if I'm cut out again, but I would heavily recommend.
Yeah.
Am I present? Am I back now?
You're good now. You're good.
I would heavily recommend like learning these or remembering what they sort of look like. Just because if they ever give you a liver picture, it will look basically the same. I think partially because they use the same pictures. So definitely learn these pictures or remember these pictures and how they look. In terms of like the iconic features. So the central veins are important in these hepatic triads, if you can see them, but have fun looking at that. Okay, so the gallbladder. So the gallbladder is located posterior to the liver, in the right hypochondrium again. Has 3 parts, so the fundus, the body, and the neck. So the fundus is this area here, basically the end, the body, in between the neck at the end here. The neck also has an area called the Hartmann's pouch, which is fold it doesn't really showcase here, but it's basically a fold before the cystic duct happened, which is also quite tortuous, where gallstones can kind of lodge and sort of exist, causing cholecystitis, leading to cholecystitis in the end, which we'll talk about on Sunday as well. The innervation is what it is. The vascular supply is cystic artery. The venous drainage is a cystic vein. And it's kind of this what it is there. Okay, so the pancreas. So the pancreas is retroperitoneal except for the tail, which is intraperitoneal. And the duodenum will curve around the head of the pancreas, and the SMA lies between the neck of the pancreas and the uncinate process. It's divided into 5 parts. The head is the widest part, lying close to the duodenum. So it's the head, the uncinate process, the neck, the body, and the tail. And I guess you can almost think of the tail tickles the spleen, which would be here.
And just one point about the SMA and the SMV. Like if you go to the pancreas picture, so just remembering that it goes, when they're running sort of up and down, they go behind and then in front of the uncinate process. So it kind of like threads the needle. And you can see that on CT. So sometimes one of the ways that you identify the SMA and the SMV on a like CT on a transverse scan is that you can see the pancreas kind of curving back, and then the SMA and SMV run up and down in between that curvature.
Yeah. So like imagine it's like running through this area here. And on CT, just remember, like imagine that happening, and you'll have fun there. The pancreatic duct lies within the length of the pancreas. It goes through the whole thing, which is this kind of line here, and will enter and connect with the bile duct here and go into the ampulla ovata and the pancreaticoduodenal papilla. Okay, so this is located in the epigastrium and therefore has a lot of sites of pain. It's located to a whole bunch of different things, and so therefore it has several structures that can be affected by it. So the stomach anteriorly with the lesser sac in between exists in front of it. The duodenum curls around the pancreas. D1 lies anterior, D2 laterally, and D3 inferior. The common bile duct descends behind the head into the pancreas and meeting up with it. The spleen is at the end. This is looking here. Lateral and connected to the tail of the pancreas. And the aorta and the IVC lie posterior to the head of the pancreas, so lie back here. As you can see, it's drawn basically. And the SMA lies posterior, as we talked about a lot, to the head, or to the neck, sorry, and then we'll go anterior to the uncinate process of these arteries here. And the splenic artery will travel the superior border of the pancreas across there. Okay, and the pancreas has these kind of innervations in the vascular supply and the vascular drainage, and these lymph nodes as well. In terms of histology, pancreas is also important. So histologically, there's 2 groups of cells, the exocrine acini and the islet of Langerhans. So the exocrine acini will secrete digestive pancreatic enzymes into the duodenum. They are exocrine glands because they are going to the outside. You think yourself almost, the human body's a donut. They're going into the middle of the donut, I guess. The islet of Langerhans, these are the endocrine cells, and these are the alpha and beta cells. I think I've swapped that around. So insulin's from the beta, glucagon from the alpha, pretty sure. And these will secrete into the blood, and they're such endocrine cells. These will look different, and the acini will appear like grape-like clusters, whereas the islet of Langerhans will be much denser and are richly vascularized, which you will hopefully see here. So the islet of Langerhans are very sort of dense, and they're also different color, which helps. And then the acinis, which are these kind of basically everything else, are these kind of cluster shaped sort of structures here. So these clusters are acinis, and these islets of Langerhans, these much more dense cells. Again, remember these little diagrams. Again, remember like kind of they look like, because they are important for that reason. And they'll kind of come up again. Okay, the spleen. This is not very important, but the spleen is located in the upper left quadrant. It's covered by the 9th, 10th, and 11th ribs, which, if broken, can rupture the spleen. The spleen has a delicate fibroelastic capsule, which provides some protection, and it also allows the spleen to enlarge, giving you things such as splenomegaly when your spleen decides to kind of eat all your blood cells. But the 9th, 10th, and 11th ribs can rupture the spleen, and that can cause heavy bleeding going through there. Again, all these kind of things here for future notice in case you ever need them at some point for whatever reason, or for curiosity's sake, I guess. And that concludes what I am going today. So does anyone have any questions, any queries, any concerns about any of that? Have I just tired at everyone? No.
We can like sit on for a couple minutes afterwards, and like if anyone wants to ask questions, they can.
I will stop the recording now.